The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
And welcome back to Curbsiders. I'm Dr. Moni Amin, joined by my eternally effervescent co-host, Dr. Meredith Trubitt. How are you this evening, morning?
It's afternoon. Round 2, I guess, here.
Yeah.
Inside joke for those who are here.
I can't keep it straight, guys. We're in Las Vegas for SHM Converge, so it's not one of our sort of normal formatted episodes, but we're so excited. We have such a great panel of guests to help recap all the action with us. But before we get to those awesome guests, Meredith, will you please remind the good people in the audience what it is we do on this show?
Sure, Moni. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And tonight we're distilling some of that expert opinion from all the different talks we've gone to today.
Yeah, no, it's just a great way to, honestly, for me to, reframe, digest, and then regurgitate for the masses, if you will. But our guests, Dr. Caroline Coleman, our infographic extraordinaire for the hospital medicine team. Dr. Avio Glosser, also known as the Chief of Periop Medicine at Kashlak Memorial. Dr. Michelle Brooks from Kashlak Southwest-ish, sure. And Dr. Rahul Ganatra, who you may be familiar with from our Hotcake series. Just an awesome all-star team joining us. There might be some other voices we'll introduce you to along the way as well. Before we get too far in, I'd like to start. Actually, Meredith, I'm going to just take it right over. First talk I went to was the care for the hospitalized homeless patient. And the speaker started with a really, I think, poignant, kind of jarring quote, really, which is, "Unless you've experienced this, I can't talk about it with you," which was a patient of hers. And I just felt like that was such a good way to just reframe it for your brain, which is most of us have not ever been in that circumstance. And so we have to kind of accept that initial disconnect and then very quickly work to try to build as much rapport as we can. And she referenced a book called Slow Medicine by Victoria Sweet, something that I'm sure some of the listeners have listened to before or read before. And then kind of the context of why we should even be talking about this, she set by sharing some really impressive statistics about homelessness. So in 2023, it was reported that almost 1 million people experienced homelessness, and that it's been on the rise over the last several years. I think a lot of us rightfully would attribute some of that to the pandemic, and that the gap between men and women in homelessness is shrinking. So historically, men have been categorized as that more than women for a variety of reasons, and then that gap is narrowing, unfortunately. And then, there was a lot of great content, but I think the few things about the hospitalized, hospital-specific stuff that I found to be important kind of reminded me of our psych episode last year with Dr. Gluth, which was just really thinking about addressing as many things as you can while you have a patient with homelessness with you, because it's hard for them to get back. They may not come back. And so always be asking why for some of their issues. So nutrition. Frequently, these patients will ask for double portions, and sure, it might sound weird to people, but ask about their food insecurity. That might be a clue that they're homeless if they haven't already told you that. Thinking about any potential solutions you can offer, over-the-counter vitamins are expensive, so if you can prescribe them, that'd be great. Social services teams, food stamps, things like that. Mobility challenges. Ask why is the patient in the wheelchair instead of just assuming there's already a reason that you haven't already addressed. PT, OT for the win, as usual, and making sure that you understand that mobility is important, yes, for them to move, but also it helps them get their food, protects themselves, get to their clinic appointments, and even getting them to be able to get social assistance. They have to be able to be mobile. And then things about behavioral outbursts that might be from underlying psych issues, but it could also just be they've had negative experiences with healthcare in the past. So just, again, always be asking why. And we should be careful of documentation, the language that we use. So I think we all probably have some feelings about against medical advice discharges. I think there's even a things we do for no reason for that one. Non-compliance, or, patients that seem to frequently get their meds stolen, it may not be nefarious. It might literally be they had to go pee, they had to leave their things behind. There's a street sweep, actual story shared by the speaker, kind of thing. And then the last part that I really, it really is something to think about is this disconnection from community people experience when they're homeless. And I think in where we work, we experience this a lot where there's like a lack of surrogate decision makers. Like they're so disconnected from community that when these decisions need to be made about their health care, they don't have the social support, or if they don't have capacity, don't have the surrogate decision makers to help. So just keeping those hospital specific things that we can address while they're there with us is really important. And then just one last thing that I thought was interesting was the three most common reasons a patient who is homeless is admitted. Number one, I thought would be a common thing being common, like cardiac. It was actually psych issues, then injury, then cardiac issues, which again reminded me a lot of our psych episode. So anyway, I thought those were kind of the big take home points from that one.
Yeah, I think that's a great reminder to always ask why for this population and for many others. If you have nothing else to add, I can take us to our next one. So Rahul and I both went to the GI talk. So switching gears by kind of a lot, but that's okay. Do you want to get us started on your favorite?
Yeah, sure.
pearls?
I'd be happy to. So this is from the Updates in Gastroenterology, which was given by Benjamin Verplanke, who is a hospitalist at NYU. So he covered the American College of Gastroenterology 2023 update for the management of acute pancreatitis, something we take care of a lot in the inpatient setting. And I'll just briefly mention two pieces of evidence that kind of fleshed out my understanding of why we do some of the things we do. But before I talk about that, I just have to mention something that he said that is going to live rent-free in my brain forever now, and it is concerning the effect of scorpion bites on pancreatitis. I feel like everyone learns about that in school, and then you never see it, and you just sound like a fool if you bring it up. Almost all the scorpion envenomation causes of pancreatitis happen in Brazil and northern Venezuela, and it's kind of a big deal there. It's like 10,000 cases a year, and it's caused by the sting of the Titius cerulatus scorpion. I practice that a lot in my head. So I think everyone practicing medicine outside of that setting can probably safely take scorpion stings off your differential for acute pancreatitis.
So would you say that asking about scorpion exposures is now a thing we do for no reason in the United States?
Zing. Tony Brew, if you're listening, I think that should make it into next year's talk. For sure. I'm definitely never going to. I'm going to bring this up if someone mentions it for pancreatitis. So the pieces of evidence that we covered in talking about the updates in management of pancreatitis, we talked about the waterfall trial, which we discussed on episode 367, a hotcakes episode. We talked about studies supporting the use of lactated ringers over normal saline. But one thing that really stuck with me was a paper that he mentioned on the timing of cholecystectomy in acute biliary pancreatitis. I think we all know that the guidelines recommend patients get a cholecystectomy during the index admission, but have definitely been in situations where that doesn't always happen. And I've always wondered, how strong is the evidence base supporting that really needs to happen right away? And he talked about a paper by Van Baal and colleagues from 2012 that we can link in the show notes. And this was a systematic review and meta-analysis of studies on the timing of cholecystectomy after biliary pancreatitis. And those authors found that 18% of patients who underwent delayed cholecystectomy, and that's anywhere from 3 to 6 weeks after discharge, 18% of patients had readmissions for recurrent biliary events, compared with no patients who underwent cholecystectomy during the interval admission. So that helps me understand it's really important to talk with your surgeons and get patients teed up for a cholecystectomy during the index admission if they're healthy enough for it.
Yeah, that one stuck out to me a lot, especially the group that had it during the index, and then there was no readmissions. It wasn't just it reduced it a little bit. I mean, it was really pretty stark difference.
Yep.
And I know that Dr. Amin and I just shared a patient like this on service. So, and then I think he went in and talked a little bit about after the pancreatitis section into the ulcerative colitis. I would say I'm way more comfortable with pancreatitis than UC. So I don't know if you had anything else that stuck out to you on the UC section.
No, I mean, just learning more about the natural history of ulcerative colitis I found really useful. I learned that something like 1 in 4 patients who are diagnosed with UC will ultimately require hospitalization at some point for symptoms. And among patients who are hospitalized for symptoms with UC, up to 40% of them are going to ultimately require colectomy. So it's a big deal. I think we're used to seeing patients who are hospitalized who get started on steroids and get better and go home. But I thought that was kind of a useful reminder that these patients can get quite sick. So I'll be on the lookout for that.
Yeah, I thought that he used a graphic that I thought was like a good way of describing kind of UC, which is like the inpatient stay. He had like the tip of the iceberg, and really like the inpatient stay is really just that tip of the iceberg. And then the rest will kind of be their outpatient management. What I liked about it is highlighting kind of like on admission what to think about for these patients that you see with UC for just initial labs, because it can impact like decision making for your specialist for the treatment they're going to get. So the two that stuck out to me that I have never thought about is getting a cholesterol panel and magnesium, because it will help dictate decisions for infliximab versus cyclosporin, which maybe other people knew, but I did not. Okay, cool. Thanks for all the shaking of heads in here. So I thought that was just kind of really with like in my wheelhouse as the hospitalist, what I can be thinking about to like help move this patient's care along. And then like knowing that they're going to be on immunosuppressives in the future, like getting that quant gold, hep B serologies and all of that too on admission, so that can help like tee them up for outpatient care as well. So I just thought those were good things to really be within our wheelhouse. I think those were most of my highlights from that talk. I think the one other one that came up, but will probably come up in other settings, is the GLP-1s in the periop setting. So we'll probably save that one. What other talks did other people go to this morning?
Yeah, I went to a delirium management talk and it was titled "Ta-da, No Magic Tricks Required." If you're not familiar with SHM, there's often a thematic theme running through the talk titles based on the city that we are located in, but ta-da actually has some special meaning for this talk, which will be one of my takeaway pearls. And I did choose this talk based on my role being the medical director of a pre-op clinic, thinking like, what can I extrapolate to the surgical setting from the non-surgical setting? And there was actually a lot of tie-ins, so I was vigorously head nodding through it. But for starters, the two speakers introduced the concept that acute delirium should be thought of as acute organ dysfunction, like we would think of acute heart failure or cardiogenic shock or acute kidney injury or acute respiratory failure. This is acute brain damage, and it's not a one and done situation. So you may develop CKD from an episode of acute kidney injury, or you might develop a chronic heart failure from an MI. But that not only does dementia increase your risk of delirium, but delirium can accelerate cognitive decline in the long run. They also talked about, and I'll share more in a sec, about patient-centered education, family and caregiver education, and that was one of the tie-ins. People need to know how this affects their long-term trajectory. So the speakers use the mnemonic ta-da as a way to remember management options and opportunities. So T is tolerate, sort of leaning into a patient who might be agitated or have a hyperactive delirium. So sort of keeping them safe in the room and kind of meeting them where they are, pacing with them, observing their safety. It does require a lot of supervision, and that's a challenge in current healthcare staffing models. Tolerate in a way of using those context clues that the patient might be giving you for what might be one of the triggers. Are they in pain? Are they hungry? Do they have urinary retention? A for anticipate. And that really was a lot of the proactive risk reduction strategies. And they emphasized several times during the talk that delirium is much easier to prevent than it is to treat and reverse. So thinking about tethers, avoiding lines, DCing Foleys, DCing telemetry, de-escalating or avoiding prescribing high-risk medications from the Beers list. And one of the pearls that I was vigorously vigorously nodding my head about, heading my nod, that's a new one, was that pre-op clinics, so for patients who might be at risk for post-op delirium, that pre-op clinics have a high-value care opportunity to de-escalate high-risk medications, especially anticholinergics. It is April, it's pollen season. We are actively de-escalating diphenhydramine in my pre-op clinic right now. And also in opportunities to promote cognitive prehab strategies in select patients, so engaging in brain games. So if somebody's coming into the hospital rather than an acute admission, how can you anticipate and risk reduce? And then the DA and TADA was don't agitate. And sometimes going in and saying, you got to stay in bed, or resorting to restraints first is actually going to make things worse before they get better. And not necessarily part of their slides, but there's a really, really astute question from the audience at the end. Like, how can we work with our ancillary staff partners, especially our nursing colleagues, especially when we're on call, it's night, and we're getting paged to please prescribe something, this patient's delirious and agitated, or please put in a order for restraints. And the speakers had a very, very both patient-centric and healthcare colleague-centric, compassionate response, and provided some coaching for saying, going to the bedside, talking to the nurses and saying, I get it. This is harder for you than it is for me. It's probably harder for you than it is for the patient right now. But me not ordering restraints, me not ordering benzos really is in this patient's best interest. What can we do together to keep them safe in their room at this time? And the other really, really cool pearl with this was at the transitions of care, and they shared data that about 50% of discharge summaries mention delirium when it's been diagnosed and recognized in the hospital, and that a very small percentage of patient discharge instructions or the after visit summary teach patients what they experienced. So it's not just that long-term benefit, you had this could affect your long-term trajectory as a geriatric patient, but also driving instructions or acknowledging that someone might have brain fog for a week or so and may not feel ready to go back to work, if you were delirious with your acute pneumonia.
Yeah. Did they give you any suggestion on how to communicate delirium to the patient or their family on expectations, specific lines to use? I always struggle with that because I'm like, hey, but I guess maybe the beginning is the right one where you're saying this is acute kind of brain injury that happened. Our hope is that it improves, but it is possible that can develop into a chronic disease process. I don't know if anyone else has good lines, but
yeah, I don't think that they had a specific line. I really, really appreciate that question, but just situational awareness that patients and their families aren't getting any counseling most of the time. There is a article that they included a screen grab of, and it's from 2021. It's by Walston and Ralston in Age and Aging. And it's called No One Told Me I Couldn't Drive with Delirium. But I think you're similar to how we would translate acute kidney injury or acute respiratory failure into lay-centered terms. I think we should lean in to those strategies as well. This agitation, this hyperactivity, this lack of attention, this was your brain being stressed while you were very, very sick. They also said that we do a terrible job collectively, royal we, of recognizing hypoactive delirium, as well as also counseling family at the bedside. They aren't just sleeping off the illness. This is something that we need to lean into and evaluate.
Yeah, I think that's all very pertinent. And then just the pre-op eval and going through it ahead of time, we should do that more, guys.
We should. And there are society recommendations that pre-op clinics or in the pre-op setting, we should be doing cognitive screening as part of a holistic risk assessment, risk reduction, especially for attempting to predict delirium risk, whether or not a patient has dementia or cognitive impairment.
No, super helpful. Michelle, Dr. Brooks, what you got?
Thanks, Moni. I've been working on my radio voice. I got to go to adaptive leadership in hospital medicine, effectively dealing with change and challenging situations. Interestingly, it was standing room only. And I wonder if many of me and my colleagues at Six Flags Over Cashlack south. If many people are dealing with change and challenging situations currently, since there was standing room only. So the first slide that they presented was that emotional intelligence is twice as important as technical skills or IQ. And I think that was just a great start to the entire talk, a great lead-in. They talked about the 5 components of emotional intelligence, including self-awareness, self-regulation, motivation, empathy, and social skills, and went through each of those in great detail. I think what I'm learning as a leader in my space in educational leadership and hospital medicine leadership is that self-regulation is very important. And how do we face leadership challenges in a way that is productive and moves us forward rather than react to everything. So I think that was very helpful to hear. They also talked about empathy in terms of listening deliberately, assuming good intention. And this is stuff that I have heard of before in things like crucial conversations where you're trying not to tell yourself your own story about what's going on, but really get the information from the person, listen deliberately, and then assume those good intention. I think I've been the victim of like an innocuous thing becoming somehow very nefarious. So if I bring cookies to a nursing station, and which is kind of one of the examples that they used, someone kind of bringing dinner to the nurses while they're working as a nocturnist, very innocuous, very trying to be friendly, and somehow interpreted as very nefarious. How is that really challenging the people that are doing that and pointing out that that's a story that they're telling themselves, and doing that in a way that says, that's really not in line with our mission. That's challenging them when they're acting unfairly is actually empathetic. We got to work through a case, which was really fun and therapeutic for me. So that was great. I think the workshop was set up very well, and that it had 2 very pertinent and relative cases. And then Dr. Aron spoke a lot about communication and how there's basically in sort of business communication, there's 4 different types of communication: analytical, intuitive, functional, and personal. And that many leaders tend to live in this like analytical phase, which are questions about numbers, where is that data coming from, and then making like, how are we sure about that, and trying to pull in the ways to motivate people is providing kind of like a what we need to do and why. So and that speaks to more than just the analytical phase of communication. It speaks to the intuitive and personal parts of that. So I thought it was very helpful, and like I said, very therapeutic in some ways.
Therapy at conferences, guys. I'm a fan. No, I think that it's really heartening to hear that it was standing room only, right? Because I think sometimes when you see those titles and you're like, I don't know, like this seems really valuable. I hope people see the value in it, and I hope they come. And clearly that was like really a thing.
Well, and I think I, in my current environment, have been exposed to a acronym called VUCA, which is volatile, uncertain, complex, and ambiguous, and as a way to describe what is going on now. But that acronym was developed like many, many years ago. And so just having that as a way to describe a current situation has given me a lot of peace that some of this stuff has probably happened before, maybe to a different scale, but I think just having a name of being able to describe what's going on is helpful.
Yeah. As a segue of how powerful appropriate language can be, I went to a really, really special session called Transforming Your Care, a Hospitalist Guide to Transgender Health. And the speaker started with some really sobering facts for me, including that 48% of transgender patients have personally experienced discrimination in healthcare environments. So we think about often what's happening out in the world beyond the walls of our healthcare system, but that half of our patients are still feeling that inside the walls, I think is really important to understand their experience. And even more sobering that a quarter of these patients avoided clinical care due to the mistreatment they received within the healthcare system, which is really I found it personally hard way to start that talk, just reminding us how important our biases are for just engaging with patients. But the speaker really, moved through appropriate language we can use to help our patients feel safe, and some really helpful tips, I think, to help you move through if you misgender patients or use the wrong language, because I think that can feel really hard for us and hard for our patients as well. And he presented this 4-step approach, which I thought was helpful to remember. So first, to thank your patient for the correction, correct yourself briefly, apologize succinctly, and move on. Don't make it to the point that your patient then needs to feel the need to apologize to you. And, that's not what this is about. Just really correct your mistake and move on, which I think gives us tools to feel like if, even though, we might be emotionally feel really bad about the mistake, we can move on and keep delivering the healthcare they need. I think an important logistical point is to think about what rooms are appropriate for our transgender patients. And I didn't know this, that it's standard of care for transgender patients to have a private room if your hospital, if your cash-lock has the resources. But if your patient does have a shared room, it should be based on their gender identity, not their gender assigned at birth, which is something that maybe you might not think of at first, but again, I can imagine would make their experience with healthcare a lot more appropriate. And then we went through a couple of cases of, salient things that might have come across the hospitalist workload sometimes. And I thought a really interesting one was how to manage a DVT that occurs when your patient is on gender-affirming care and taking estrogen. Yeah, I'd never thought of this. And there were some interesting resources we'll link in the show notes, both from UCSF or from journal articles. But I learned that transdermal estrogen is the least thrombotic formulation of estrogen. This is thought to be because it bypasses first-pass metabolism in the liver. But that if you do develop a blood clot on estrogen, there's a couple of options. It's not a hard stop for them to kind of stop receiving their gender-affirming care, and you can de-escalate to this transdermal estrogen, brief pause, other things that are in the guidelines we'll link again. But some really helpful cases, I think. So that was a really, really special talk. And the second one I went to, for the sake of time, I will just kind of refer to a previous episode we've done on this. It was rapid response, also standing room only. But I'll refer listeners back to episode 473 that we did with Dr. Noble Malik on narrow complex tachyarrhythmias. Covered a lot of the high points in that episode as well.
And I think you mentioned they did hypoxia too?
Approach to hypoxemia, and then a approach to the acutely altered patient.
I think we've done hypoxemia as well, but much longer distant time ago.
We will find it.
With the great Dr. Cyrus Askin. Yep. Michelle.
I was going to say it's interesting that idea of just treating through the clot, because I think having a clot often means as a woman you can't get hormonal treatment, replacement therapy for your menopausal symptoms and things like that. So it's interesting to me to hear that as a medication that the patient really needs and could really help their symptoms in menopause, that there's options there that may be a little bit less thrombotic.
Yeah,
maybe we could extrapolate that to a different patient population.
That distinction, the speaker brought up that that's some of the differences in data are due to different formulations that are used in gender-affirming care versus in perimenopausal or menopausal treatment, which I also learned. So there's different thrombotic risks in those as well.
All right. The next thing that we want to cover was a session that I went to in the afternoon of the first day. Was a great refresher and just like thought-provoking talk on capacity assessment from Dr. Krishna Choksi. I think we all have had the struggle of trying to figure out capacity in patients. Some of us just like kind of defer to psych every time. And I think one of the points of the talk was like, we don't always have to do that. And there's some like things that we can think of. But she started with the context, which was helpful, which is up to 26% of patients in GIM lack capacity, and that with moderate dementia patients, it goes up to 55%. And then, which is like good to know, but more alarming is that about 50% of doctors fail to recognize when someone lacks capacity. And then when they do decide to assess capacity, a third of the assessments are incorrect in either direction. So somebody that might have capacity gets an evaluation and then is determined to not have it, but they actually do. And to me, it actually reminded me of a patient I had recently who had a trach and peg and was essentially nonverbal, but could write everything. And it just took the extra time to sit and like spend that time writing, having a conversation with him and writing every day. And so I think that there was a lot of like that going on with some of the care teams involved in his care. And so that's kind of what I thought of when we were talking about that. And so she kind of talked through what we all hopefully at this point know is a capacity evaluation, but are they able to communicate clearly and consistently? Are they able to understand and comprehend the info that they're receiving? Do they appreciate what's going on? Like, how do they perceive the information and apply it to their own case? And then are they able to appropriately rationalize? And then taking it a step further, she took it to the next step, which is if you determine that somebody doesn't have capacity, the next step is to like reach out to a surrogate. And if you then determine that maybe the surrogate isn't always able to engage fully in that conversation, got to the very niche conversation that I don't think I've really thought about too much, and it's when to treat over the objections, and was very clear that it's a very, very, very isolated set of circumstances in which that should be considered, and all of them are acute. So this is not something that we should be thinking about for chronic therapies, because the biggest thing is the patient's probably not going to cooperate and engage in the care plan that you think that they need. But the things that she gave for us to think about when you're thinking through treatment over objections would be imminent and serious harm. There must be a certain benefit of the intervention, and that it should be such that the benefit far outweighs the risk in the intervention. There's a lot of other great stuff in the doc, but those are the things that I felt were like pertinent and also just really good thought-provoking stuff for us that we all deal with on the inpatient side.
Did she define certain benefit?
She did. If I would probably misquote her if I tried to do that right now, though.
So but was it like 100% certain?
No. That's the thing, right? With these ethics conversations is that they're never like, that's why they're ethical dilemmas, right? Like we don't know for sure if something is going to go a certain way. And I think one of the things that she gave like a case where a patient could use a blood transfusion, but technically certain benefit, but then like, weighing all of that. And we've all had patients with, certain religious beliefs or things like that. And like, just because they have as long as they're able to communicate and understand, appreciate, rationalize, like that's really not up to us necessarily.
Yeah, I like certainly a pain point. I like the part that she talked about for when the surrogate you have questions about too. Mm-hmm. So did she give you guys any advice on like how to navigate that? Do you just have to find another surrogate?
You can, but it's really she kind of jumped to like if you're hitting a wall there too, and essentially doing a capacity assessment there too. The example she gave was the initial patient had like technically had religious beliefs, but then couldn't tie those back to why they were making their decision making. And so then they got the patient's mother involved. The patient's mother was like, well, all he needs is vitamins and minerals and he'll be okay, was her rationale to take, right? And so that seemed a bit maybe outside of what would be appropriate in the case. And so that was when and it turns out that there was no certain benefit. And again, these are all like muddy and ethically challenging. But anyway, so I did that's what I found to be unique about this talk in capacity, because I think it always just stops at like the patient's capacity and then like we're done. And then of course, always not assuming if that someone has capacity, like you actually have to put the work in to figure out if they have it. Rahul, what did you go to this afternoon session?
Yeah. I went to talks that addressed easier issues to deal with than that. That's going to be clanging around in my head for a while. I went to a talk on mastering heart failure management by Salman Rahman and Laura Derry. And they gave a nice overview of the recent ACC and AHA guidelines for guideline-directed medical therapy for heart failure with reduced and preserved ejection fraction. They talked about the STRONG HF trial, which I remember we discussed back on episode 393. That trial really established firmly that getting patients with heart failure who are hospitalized for acute decompensation started on all the pillars of guideline-directed medical therapy really should be an urgent priority for those of us who do inpatient medicine. So they kind of reaffirmed that. And the speakers also provided some practical guidance for how they sequence the initiation of these medications at their institution. So they like to start with an ARNI first. And the rationale there is that you get some vasodilation from that, and that can improve natriuresis and diuresis. They then go to the MRAs because there's a mild diuretic effect and a potassium sparing effect, as we know, that can be useful if you're running into issues with hypokalemia. I also personally like the idea of starting the two most potassium affecting meds while a patient is under my watch in the hospital. I feel like if there's going to be issues with hyperkalemia, hopefully we'll catch them then. Then they typically start the SGLT2 inhibitors third. And then the only clear recommendation from the guidelines is what comes next, which is waiting until a patient is euvolemic to start a beta blocker in heart failure with reduced ejection fraction. So that's sort of the sequence they provided. And then we reviewed the strength of the evidence for the components of GDMT for heart failure with preserved ejection fraction. And really the headline there is that SGLT2 inhibitors kind of have the best evidence for reducing heart failure exacerbations in this population. And they talked a little bit about things to look for on the horizon. Tirzepatide showed some really promising endpoints. Hasn't made it into guidelines yet, but that's something that seems likely in the future.
Cool. What'd you go to next?
All right, next. Talked a lot about the heart, so I had to go over to the heart's trusty partner, the kidney. I went to a talk by Ethan Mullich-Hugh on the care of the transplanted kidney. And so I've learned a lot of just fascinating tidbits here. I haven't cared for a lot of patients with renal transplants, but I was surprised to learn that this is actually the most common solid organ transplant in the world. And I care for a lot of patients with hypertension, a lot of patients with AKI, and so I was looking for kind of an approach to those things in this specific patient population. And the speaker talked about causes of hypertension after transplant. In addition to the usual donor factors like age and essential hypertension, there's also graft factors like rejection, things related to renal artery stenosis from the surgical implantation of the artery, and then finally immunosuppression. Calcineurin inhibitors and steroids can both contribute to hypertension, so some additional causes to look for in patients with a transplant. And then the other thing the speaker mentioned that really stuck with me was, in addition to the kind of usual pre-renal, intrinsic, and post-renal causes of AKI, there's a bunch of additional things to think about in patients with a renal transplant. Calcineurin inhibitors and renal artery stenosis can both cause pre-renal AKI in those patients. That's something to look for. Post-renal causes, you also have to worry about hydronephrosis from the implanted ureter. Sometimes that needs stenting or even surgical reimplantation. So talk to your urologists and transplant surgeons early on for those patients. And then kind of the biggest and most intimidating category for me was the intrinsic causes, because there's just a bunch of stuff that can cause intrinsic renal injury in patients who've had a transplant. And we could do a whole episode on this if we haven't already, but this is an area where I would definitely be seeking expert consultation. But, the pre and post renal stuff, I can definitely incorporate, thinking about medication side effects and anatomic causes into my workup.
Yeah, I always just consult renal.
I want to have impressive things to say when I call them.
I respect that.
Yeah.
Okay, I'll take it next. So I'm going to go to maybe one of the more non-traditional spaces for SHM that just started last year, but attended the Med TED Talk, which is a cool opportunity for junior faculty to apply and get to give an 8-minute talk on a topic of their choosing. And so it's a great way to kind of see junior faculty really get to, pick something that they're passionate about to give their talks on. And our very own Caroline Coleman was one of the competitors. So shout out to a Curb,
Staple.
Yeah, thank you. And her talk was marvelous with obviously beautiful graphics because she does our graphics. But what I actually really enjoyed about it was that I thought it was great to see junior faculty who had clear interest in a lot of different spaces. People who did talks on things that touched on addiction and like QI and like just really like staple clinical like questions as well as like medical education. And so I think it was like a nice look into the future of what some of the talks can be here. But just wanted to highlight 2 teaching points that I had. One was for one person gave a talk on buprenorphine and specifically highlighting kind of the risk of precipitated withdrawal, especially things to consider in an age when we are seeing most patients on fentanyl. And the teaching point that I thought that I hadn't thought as much about was how I always think of fentanyl as short acting. But if someone is using fentanyl on a regular basis, it ends up in the adipose tissue. And so then it can be coming out in a much slower process over days. And so really still utilizing like your cows to determine when withdrawal phase to determine when a good time to start the buprenorphine is. So I thought that was a really good teaching point. And then the other one is I obviously enjoyed learning a little bit about contrast nephropathy. And so thing we do for no reason, we'll probably talk about it on a later date for this like show. But, I think there's always a fear and, kind of plugging also the episode that will come out for us after this recap is in terms of things we do for no reason, there's kind of risk of, harm when we do something to a patient for sure. But there's also always the risk to consider when we don't do treatment. And so to be just mindful of both of those things, I think is a good like teaching point and frame of reference for many hospitalists and many questions we have on a regular basis. So with that, I know Avi went to some leadership things, so kind of all the avenues of hospital medicine.
I did, and the speaker, who was phenomenal, joked that he thinks he has the longest title of any talk here, but it was business updates for the hospitalist, the top business articles of 2024 that'll change the way you lead, do your job, and practice medicine, with an Oxford comma. And I was curious because I thought there was going to be a lot of financial content and budgeting, and it was very much an overlap with sort of leadership pearls, high EQ leadership, and leaned into a lot to the humanism of medicine and what we can pull from the business research, because they can do things and pay research subjects to do things that we can't really do in medicine, but reviewed business journals and shared 7 articles. And I'm going to share 3 pearls that I walked away with. The first one, and this was studied, like a sociological study, that giving advice or framing something as advice rather than an opinion or just statement of like, this is an available fact, do with it what you will, was much, much better received. And that was in the workplace. But the speaker readily transmitted it over to the patient setting. And I think we have that information too, where patients want counseling and they want options, but they also want to hear like, what would you do? Or if this was my loved one, this is what I would do. Or, these are options A, B, and C, but, I would point you towards this one. So that was really validating. And also then transmits, crosses over to the leadership and faculty development and team building arena. The second one was anticipatory gratitude can prevent future distress. So being upfront with thanks, especially when asking people to pick up more work, if we're short-staffed, which never happens in hospital medicine, or things are really tight during flu and respiratory illness season in the hospital, that including thanks in the original ask, or we need somebody to pick up a shift this weekend. That was the example he kept using, like picking up extra shifts. Yes, you should also thank people after the fact, but thank you in advance for chipping in, for considering. And someone also asked in the audience, at what point does that feel like, do you cross the line for this being disingenuous? And people just being like, you're just throwing out thanks, but you don't actually care, like you're not actually thanking us. And I said, this is part of the leadership skill too, like being genuine, demonstrating caring, being mindful of your words. And then the last of the pearls, and he had 7 articles, but I want to share a third one, is that communicating that you enjoy what you do will make others more likely to ascribe or subscribe or follow your advice, not opinion. And this some of the study he studied this in like direct to consumer advertisements on like online or social media, that if someone, I think there was like a plumber or something, I really love fixing pipes and I'm good at it. Like that's going to be better received than like, need a plumber, call me. But then also communicating to your teammates, again, being genuine and not just saccharine or Pollyanna, but communicating to your team. Or if you're in a situation where you actually do genuinely convey to a patient that you want to be there, you want to be caring for them, they're more likely to follow your advice. So I would think, if you're counseling about tobacco cessation and you're just, oh, this is a drag, I've got to do this again for another patient, it's not going to be well received. But if you say like, I'm here and I really care that I can be with you talking to you about this today, it's going to land and stick.
Yeah, two thoughts. The first is the audience member had the exact question that I did, which is, when does that cross the line into disingenuous? Did they give any language to use in that setting? Like, because I think genuine authenticity, those are all things we all strive for. Some people are better at it than others, but like, were there any specific phrases or things that seem to like be better received?
Yeah, that's a really, really appropriate question, because it's like, again, I want my words to have impact and not become too superficial or predictable. One of the pearls that he recommended is when you follow up with the thanks for having done this, is specifically call out maybe who did pick up the extra shifts. Or when you go from thank you in advance for considering, or thank you for all like being in this together, when you then provide the back end feedback, be granular and specific.
Cool. And then
show that you noticed what was actually done.
No, I like that specificity. And then the other thought that I just bringing it like touching everything. So he talked about it in the leadership setting, in the patient care setting. And then I remember when I was a resident, the attendings that would come in and be like, this is the favorite part of my job. I want to be here. I love teaching residents. Like that was always like such a great way to start. So it's like the same thing, but anyway.
I appreciate you sharing that, because I didn't even think about applying it to the educational setting, but absolutely. Or, think about like college lecturers, when somebody comes in, they're like, all right, I'm giving this lecture today, or med school or grad school or whatever program you're in. But if someone is like, and I think that if someone is genuinely passionate about what they do, you can tell.
For sure. Cool. Some great pearls from the afternoon session, day one.
I started my day reviewing and updating our practices on inpatient alcohol withdrawal. And we started with how we got to the place of using benzos as the cornerstone of a lot of our inpatient withdrawal care. And in 1994 was the study that we based that treatment on, of whether we should do PRN versus scheduled benzos, and how we started with PRN benzos. But we're all familiar with the flaws of benzo-based therapy. So we talked about a couple of alternatives to that. There's no randomized controlled trial data, but there's a couple cool single center studies that give either non-benzo alternatives like anticonvulsants or alpha-2 agonist therapy. So we can link those in the show notes, but those had some positive findings, again, pending randomized controlled trial data. But I think the hot topic is phenobarbital. And I know Meredith has a couple of thoughts on this, but they mentioned 3 single center studies in 2023 and then 2 in 2024, so 3 total, that had various phenobarb regimens or schedules that they followed, different doses. They all had a lot of heterogeneity, but they all had positive outcomes. Some looked at the sort of feared phenobarb side effect of respiratory depression, and they didn't see a signal for that. So I thought that was at least interesting to start maybe the basis for some randomized data on that.
Yeah, my hot take is just like, I am uncomfortable with phenobarb. I've never really used it, and I've never been at a site that uses it. And I do think that there's probably a little bit more like both education and just like logistics that go into it. But like the mechanism behind it like makes sense to me. And so like I understand why it should work. And so in the meantime, I've been favoring like my long acting benzos, which I'm just a little bit more comfortable with.
And that brings up a good point, that these studies were conducted anywhere from med-surg, where I know both of us practice, but including step down and ICU level care. So like you said, this is something that is definitely evolving, and we're not seeing much of in our cash lack as well. The next talk I went to is something we do see a lot of in our cash Slack, which is MRSA-NAIRS PCR swabs, or just MRSA swabs, when it helps and when it doesn't. So we went through 3 case uses of the MRSA-NAIRS swab. And the first one that has the best data for it is CAP and HAP, so community-acquired pneumonia and hospital-acquired pneumonia. And we went through a little math. We did some likelihood ratios, but a meta-analysis showed that the sensitivity and specificity for MRSA in CAP and HCAP, that's back when we were using HCAP, was 85% and 92%. So it's a really great study, or really great test rather. And the likelihood ratios, the positive likelihood ratio is 10.8, negative likelihood ratio is 0.16. So a really strong study for HAP and for CAP. Another way to say that would be if the patient has a low pretest probability and they have a negative MRSA swab, it's appropriate to stop the MRSA coverage, often vancomycin. But if they have a high pretest probability and a negative MRSA swab, the guidelines recommend continuing vanc and still waiting for your culture data, if that was obtained, whether that's blood or sputum, to de-escalate care. And the speaker made an important point that even with these cool tests that we have, to still follow the patient's clinical trajectory. So if they're improving, keep them on the therapy they have, and don't use this MRSA-NAIRS to ultimately trump your clinical judgment. So that was the best data for the MRSA-NAIRS. Some places that we sometimes see it used that have less strong data is for ventilator-associated pneumonia. This wasn't addressed in the most recent HAP and VAP guidelines by IDSA. That was back in 2016. But a negative MRSA swab in that case for VAP may not reliably exclude MRSA, so don't be using it as much to guide your clinical judgment there. And same thing for skin and soft tissue infections. We sometimes see that as well. And again, the negative likelihood ratio is just not strong at all in this case. It's 0.56, so it's just not going to change your clinical management as much. So the pearl I took home is for CAP and for HAP. It is a really helpful test for de-escalating your vancomycin. So we normally think the cardiologists have the coolest trial studies names, but there's a really neat upcoming IED study called the Stop Vanc trial, where we'll have the first randomized controlled trial data on using MRSA swabs to guide antibiotic de-escalation. So maybe next SHM we'll be able to talk about that one.
What a name.
What a name.
So overall, they're saying, obviously don't blanket MRSA test people, which I think most institutions have stopped. But these very specific use cases seem to be like a good space to use them.
Agreed. For CAP and for HAP, helpful to de-escalate your MRSA coverage if you have low pretest probability in the first place.
Great. Michelle?
I got to go to Gabby Frank's bugs, bites, and fever, where she covered mainly 3 arthropod-borne illnesses or viruses, which is how we get arthropod-borne viruses is how we get arboviruses. So these are illnesses that produce fever, arthralgia, myalgia, headaches, and rashes, and sometimes other symptoms as well. And most of those people will have a travel history somewhere in the last 14 days. So I think the things that I took home were the 3 main ones that we talked about were dengue, which can affect up to 100 million people per year, very low death rate, but up to 20,000 deaths per year, chikungunya and Zika. And like I said, all of these have similar prodromes, symptoms, or in the case of dengue, the person can be asymptomatic. But she gave us pretty quick tips about how to differentiate between the 3. And the first is that dengue, they will sometimes have serositis, including like pleuritis, pleural effusions, pericardial effusions, and ascites. And that can sometimes differentiate between the other 2. And then chikungunya, actually the majority of those are not going to be asymptomatic. About 15% are asymptomatic, and the rest are floridly symptomatic and have arthritis as a main complaint. And apparently the name chikungunya, and I don't know which language this is from, but Dr. Frank talked about it, means to become contorted in that native language. And so those people actually have disabling polyarthralgias that can persist for several months. And so that's a way that you can kind of distinguish between the 2 of those, serositis for dengue, more acute, they have several that are asymptomatic cases. And then chikungunya, everybody's pretty much symptomatic. And there's a lot more arthralgias. And then Zika is similar to chikungunya, but they also have adenopathies and pharyngitis. So I thought those were 3 things that were very helpful to distinguish between those different arthropod-borne illnesses. And then the final tip that she gave, and she kind of gave it after the talk was pretty much over, was to spray permethrin on your clothes when you're traveling to endemic areas as part of decreasing the spread, or it's not technically vector control, but you're basically like trying to control the vector from getting to you. And you can air dry it, and then the permethrin will stay on your clothes for several washes. And so probably the entire time that you're traveling, you will have permethrin infused clothes to protect you.
That's cool. I didn't know that.
That's a pro tip.
Yeah.
I think it's a very pro tip. There are some vaccines that can also protect you. Those things would probably need to be talked about with like a tropical infectious disease doctor. There is a brand new one for chikungunya that has viral like particles instead of a live attenuated virus, and it was literally just approved like within the last month. So she was sharing some late breaking stuff during her talk, but it was very interesting.
Late breaking, including the permethrin tip.
I don't know if that's late breaking because I searched online and you can get it from REI and Amazon.
Trust REI.
Over the counter spray.
Cool.
And then I did get to go to Dr. Adam Rodman and Dr. Dan Restrepo's talk on large language models. And they actually changed the title of their talk since I guess a year ago. A lot of things have changed in that landscape. And so the title of their talk was Towards a Medical Superintelligence, Reasoning Models and the Race Towards a Strange New World in Clinician-Computer Collaboration. And Dr. Rodman had published recently on how the reasoning models, the large language models that are reasoning models, outperform physicians in diagnostic accuracy, and that even when we supplement physicians with the large language models, it's like we get in our own way and we're still not better with the diagnostic accuracy. I think I'm fairly saying that. They'll probably correct me at some point. But our biases and things get in the way. And then they did a in-person demonstration of kind of comparing a large language model, a reasoning model, ChatGPT-03, with Dr. Restrepo, who's an amazing doctor and did fantastic and probably has less biases than all of us do. But it was a really interesting demonstration comparing the thought process of a physician with the reasoning model. And then we sort of talked about how this might look in the future with us either using it as a tool versus are we going to actually be using it to take histories without a doctor present? Like, are we basically going to be using it kind of like a doctor? I mean, nobody said that, but I think that's the fear, right? Like that they're just going to take over as doctoring. So I think that was just an interesting discussion about how do we interface with this? How do we collaborate with it? What is it going to look like in the next couple of years? And there's a lot of promise, and I think it was a very interesting talk. And it was standing room only, so.
No, and the AI talk that I went to last year, similarly, standing room only, and it really, I think, is driven out of fear, as you said. Like I've had definitely residents say, like, "Oh, I'm convinced that this is going to put all of us out of work." And I think the younger folk, the youngins, they interface with this stuff a little bit more frequently than maybe definitely more than I do. But I'm curious, like, how you felt like the comparison was between the physician and the.
I think the hot take is that the large language models or reasoning models perform better with diagnostic accuracy than humans currently.
Yeah. Cool. So I guess we'll all be applying for jobs soon.
For more reasons than one. But yes, absolutely. Avi, I think you spent the day in the peri-op room. So give us some highlights.
I did. I took my honorary role as chief of perioperative medicine at Kashlak very seriously. As did I take my actual day job as someone who practices and only sees patients in a pre-op clinic and is a pre-op clinic medical director very seriously. And I'm not going to go through each individual talk, but I'm going to do just a high-level overview. And one of the big takeaways for me is just this continues to be a field where for all the science and the guidelines, there's a lot of nuance and there's a lot of controversy and there's a lot of apply this in context to the patient in front of you based on the surgery they're having, based on their comorbid conditions, based on their stability. So I don't know that AI is going to take over perioperative medicine anytime soon, because I think there is definitely an art to the science. But things that some of the big takeaways, there was a phenomenal annual tradition, the Great Debate, which is now done by Dr. Jawan Irizarry and Dr. Edie Shen. They are the successors to Dr. Kurt Pfeiffer and Dr. Stephen Cohen. They talked about their two cases were timing of hip fracture surgery relative to decompensated heart failure, looking at the data on how quickly you should go to the OR versus time to medically optimize. They also, they and other discussants also spent a lot of time talking on anticoagulant management and antithrombotic management. And I will share that the best study name of the day in that room was the Monet Bridge trial. So shout out to Monet. But Monet, as in the artist, M-O-N-E-T, Bridge. And it is, I think, still recruiting or still underway, looking at cangrelor bridges, I'm doing air quotes, bridges off of clopidogrel or similar agents for patients with very recent coronary stents who need a time-sensitive surgery. So that's a hot topic and one that there isn't really clear guidance on how to manage individual patients, but hopefully more to come, including prospective research. There was a lot of discussion across talks on the GLP-1s and the SGLT2 inhibitors and the RASI, so ACEs and ARBs, both in the updates talk and anticoagulants and the Great Debate and the challenging med scenario. So if you're feeling stymied, a lot of people are still putting a lot of attention into it. I'm happy to take any specific questions about those drug classes, but I don't want to bog down this recap episode too much. I'll also say we chipped away at that and dove into that domain and those questions in the very recent episode 475. So there's content in the Curbsiders universe out there.
Great. Yeah. So kind of I did get to spend a little bit of time in the peri-op room, and just coincidentally happened to be a moment in time where you had to step out. So that just worked out so well. And this was, I was just so excited because it had wearables in the title. Basically like, your Fitbits and your Apple Watches, and thinking about that in sort of peri-op assessment, right? Because when you do a detailed history in a peri-op clinic visit, that's fine. But, maybe the objective in quotes data that we have from a wearable is something to consider. Interestingly, the audience, predominantly when polled, had never thought to use wearable data. And then next said maybe sometimes, but the speaker noted that interestingly, nobody in the room thought to question that data, which I thought was interesting because how accurate do I really think that stuff is? I don't know. So she had a couple of interesting studies that she talked about, and what I took away from them specifically with the wearables was that there's kind of a range of steps per day that people should be that were linked to decreased post-op complications. So the ideal state was about 7,500 in one particular study that looked at post-op complications from ARDS all the way to just a post-op UTI. And then the other study that talked about that seemed to be beneficial at the low end was 2,600 steps, which I thought was interesting just because we're always fixated on this 10,000 steps, right, that we talk about. And then she also talked about how people ask her from time to time, should we be looking at the distance I walked or the steps? And she said, by and large, we should be looking at the step count and not the distance. And I know you've recently given a talk somewhere else about this, so I was curious your thoughts about the wearables.
I did, and this is a topic that I'm really, really interested in myself. I did a short breakout session at the 2025 Perioperative Medicine Summit on it, so I was thrilled to see that content coming over to SHM. Dr. Nidhi Rohatgi, who's at Stanford, also included other digital health strategies like smartphones and smartphone-based apps, and even got into really cool stuff on using virtual reality or extended reality for anxiety management before surgery, coaching people through prehab and post-op rehab. But the question of wearables and step counts, I've leaned into the data, or at least said, hey, there's data maybe in the room, in the clinic room with the patient, how could I potentially use it in my assessments? I've done that for several years. I think it's really, really promising. And it does sort of span that subjective to objective data. 7,500 steps is actually a lot. Like, I've been walking all over Mandalay Bay today, and I'm only at 6,000.
Well, and I was going to say, I heard about this recently on a podcast, ironically, that the idea of like walking 10,000 steps a day originated in Japan as part of a marketing campaign. So it was like really easy and catchy and simple to just say 10K per day. But I don't know that it's based off of any like empiric research on that's
I've heard similar as well, that it's sort of this magic number because it's a nice round number, but does it actually predict outcomes? But there is one study, I'm forgetting the name, but there is one study specifically looking at wearable-based data in the pre-op setting, and 7,500 steps a day did predict worse outcomes or better outcomes.
So are you saying I only have to do 7,500 now and not 10,000 because I will take those 2,500 steps and like not walk?
But I think so. Just to do my high level overview of like where this may be going, maybe this will be a future Curbsiders episode. I don't know. That was not a shameless plug, just a topic area. I break it down into the pre-op, intra-op, and intra-op is really like patients are wearing telemetry leads. Like there are wearable devices in the OR, but post-op, like post-op inpatient and post-op outpatient. So the data we're seeing emerge in the pre-op setting is, one, can you use objectively recorded information? And there is independently published information that step count is pretty accurate in the major devices. Heart rate measurement is pretty accurate. Caloric expenditure is not accurate. But using step count as one of your tools, one of your questions in your subjective, objective, functional capacity assessment to determine if a patient needs pre-op testing or not, using baseline step count or your average step count as a predictor of post-op outcomes, and then using that as a tool for patients to have an objective data point to increase their physical activity and thereby reduce complications going into surgery. So, and I've done that with patients saying like, hey, if you're only averaging 3,000 steps a day, let's strive, let's work on a plan for you to get towards 4,000 steps a day before surgery. And then there's data emerging looking at post-op activity levels, and we're using patient-measured or patient-monitored step count after surgery as that barometer, that objective tool to get them moving sooner and faster after surgery. And specifically, I think this was a lung surgery, so thoracotomy patient population. But patients who were just told to, increase your activity, ramp up your activity as you start to feel better. But patients who had a wearable and could actually see what they were doing had less dyspnea, had better 6-minute walk time tests, and I think just did better after surgery. So I think there's a lot of research going into this. There's more to come. There are active studies. I forgot the name. It's got a cool name too. Using it for geriatric patients to improve outcomes, including cognitive or study and assess cognitive outcomes after surgery. So I would say if you're on nights, if you're admitting a patient to the hospital, if you're seeing in a pre-op clinic, it may be a tool in your history taking and risk assessment. Use your judgment. Also, if a patient maybe can't walk, like they're having a knee replacement and they can't walk 7,500 steps a day, but they're in the pool. Like, don't overlook other forms of exercise. Use your brain.
Yeah, that was actually one of her points is like, if you look at the patient and they're active, like it's probably helpful too. No, that's a good recap on the wearables. I appreciate that. Just because like I wanted so much more, but obviously there's so much to cover. I think we're going to move into a couple of the things that I was able to go to today. So first one's not the most clinical, but is relevant, I think, to hospitalists in lots of settings because it was a workshop on just being able to present better. And we all have to do presentations for one reason or another. And so there were 7 takeaways that are pretty brief that I thought I'd share from the talk. So starting with what's the message, like what is it that you're actually trying to say? What's the hook? To me, it's like it's a good pop song. You got to start with the hook and then work around that. And then practice until it's natural to you so that it's not it was like they kind of kept going back to the word authenticity, and the only way to do that is if you know it so well, you're able to tell it in your own voice and not just a full script, which I thought was helpful because I think some people think that if you practice too much, it gets rehearsed. But I think there's a kind of a balance there. Know your audience, which I think is relevant at any time. You want to make sure that it's like when you're even doing a chalk talk to residents, like make sure you're teaching to the level in the room. If one of your interns used to be a med phys, like a physiologist, and that's the only person you're teaching that day, you probably don't need to be, thinking about paring it way down. The visuals support the content and not just your slides, which you should not use them as a crutch, but also the way you look. Like you should feel and look confident. Like wear stuff that helps you feel confident in what you're doing. So one of the speakers, Dr. Mark Shapiro, he talked about how he'd never once worn cufflinks until the presentation, and he's like, I'm wearing them today and I feel awesome, which was just kind of funny. Engage with the audience and then just roll with it. Like he literally said, expect sabotage. There's going to be somebody that asks a ridiculous question, and just roll with it and like know your stuff well enough to be able to just sort of, smooth it over.
Yeah, I think I recently talked to someone who had given a talk at a national conference, and the very first question was like not really a question. It was show your own knowledge, and then how terrible the talk was. And so I think there's an art to that, right? Like being able to respond in a way that is doesn't necessarily call out the behavior, but like
it was very his idea was a lot of it was like kind of like you've given me a lot to think about, and I'm really gonna have to think about that before I'm able to talk to you about it in like a helpful way or something like in that space. Yeah, which I thought was great.
You don't know, and nothing. You don't ever have to answer anything in real time. I feel like there's ways to respond that are not necessarily responding to the intent of that question.
And then I won't get too much into the rheumatology for the hospitalist because that's actually one of our episodes we got to record while we were here. It was a great talk by Dr. Kimberly Trotter. But I will just share a couple of blurbs out of things that we don't cover in the episode and potentially could be a later episode down the road. So our episode focuses a lot on gout and then kind of our rheum NOS, if you will. But one of the general themes that when I asked her about it actually after, I was like, if there were like general themes you wanted to share about the other diseases, which she covered, like RA and lupus, the first being like always rule out infection. So seems silly, but yes, please rule out infection. And then 2, most of the time, with a few caveats, continue their chronic therapies. Very, like, obviously in like AKI and things like that, not always the best, but most of the time, continue their chronic therapies for known rheumatologic conditions. And then with giant cell, like, don't pass go, do not collect like $200, just start steroids ASAP. It's like kind of which I think we all kind of remember from med school, but it was always good to hear the reminder.
Cool. I went to a few things. Somehow I think a lot of the stuff I'm going to highlight is neuro-based, which I didn't realize actually until this moment. So cool. So the first one I went to was Parkinson's for the hospitalist. So the first thing that stuck out to me was that there is a prodromal phase for Parkinson's that lasts 1 to 2 decades prior to diagnosis.
Wait, what?
And they're just now kind of like discovering this and like recognizing maybe what some of the symptomatology is. And so it sounds like it could be pretty predictive as I get a little bit more information, but like specifically talked a little bit about like REM cycle sleep being disturbed and then other signs of like slow like movement, like being constipation. And so if you have like both of those, for instance, there's both of those symptoms that can then predict like a 50% likelihood in those next 2 decades to develop Parkinson's. And they don't totally understand like how this is like happening or whatever, but they are starting to recognize these symptoms. So that kind of blew my mind.
That's interesting. I had heard like orthostatic symptoms.
Yeah, that was on the list too.
It could precede the diagnosis of Parkinson's. And I think I've made the diagnosis once just from somebody coming in with like postural syncope. And then I was like, oh, he probably has Parkinson's.
Yeah. So he had like a list of like 20 symptoms that can actually like precede it. So I just thought it was interesting like that. I think I've like maybe missed like thinking about it a little bit. So that was really helpful. And then the other thing that I thought was like pretty, I don't know, I've just run into this a lot recently is, so like, as most of the time for the hospitalized patient with Parkinson's, you're actually seeing like advanced disease. And the only thing you really have to treat then is a slew of medications. Those medications are both maybe disease-directed medications, as well as a fair amount that, even if they're kind of at the end stage, is still like their symptomatic relief of their symptoms. And so when the Parkinson's progresses and they can no longer swallow pills, like kind of outlined a little bit of a nice like framework for how to think about getting them those meds, because it's not all the same. So some of the meds, like for instance, like you can crush them. And then if they need a G-tube later, like it can go into that G-tube. But some of the meds are long acting, and so they won't be able to be crushed. And so there's like a lot of complexity to it, which I just hadn't seen until he kind of put up, he did a nice job of like putting up a normal kind of, 12 different medications, and like 3 of them, could go this route, these 3 could go this other route. And so it kind of just hit home, like the complexity that I don't think I've been like considering as much in the inpatient side. And then the last thing I wanted to mention that was also like kind of interesting to me that I've never thought about, which is going to be the recurring theme of all my pearls today, is so because of the autonomic dysfunction, they're getting like orthostatic hypotension, and they can get hypoperfusion to like many places, and that can contribute to their symptoms. So if you see a Parkinson's patient that has shoulder pain and neck pain, it's not going to necessarily be a tension headache. They can actually just be hypoperfusing those muscles there from going from sit to stand, and that's actually called a coat hanger ache because it's like a coat hanger there. And
I've never heard of this, and I've been in medicine for a really long time. I didn't even hear about it in med school.
No.
I work really closely with our neuromuscular clinic and their deep brain stimulator assessment program, pre-op assessment, and I've never heard of that either.
Yeah. And so
coat hanger what?
Coat hanger ache.
Coat hanger ache. It's almost like a coat hanger angina, though, because they're not like getting, getting blood flow
right,
to that
it's the same
area.
thing, right?
Oh my gosh.
So
that's so cool.
And then the other one that they mentioned that, again, I think I've like just had questioned whether maybe I've like been seeing at times, is blurred vision. Then when they're also going like orthostatic, is actually most likely retinal hypoperfusion as well. And so that's why I can like come and go so quickly.
I'm glad I totally like preempted the hypoperfusion talk about knowing about postural symptoms with
you set me up.
I set you up so well.
That's what friends are for, and that's why you should come to SHM. So those were the highlights from that one.
Shameless plugging.
Did the speaker talk about deep brain stimulators, like what to do if a patient is admitted with one?
Call neuro. So they were very good, I think, at saying like, this is what you should do as a hospitalist. This is really when you've escalated beyond that. All of the devices and stuff, they're like involve either their known like movement disorder specialists or at least your inpatient neurologist who can help you with it. So yeah. I went to some of the periop stuff too today, like dipped in, but I think you actually highlighted a lot of what I was actually going to say too. So that's great. And then the other one that I went to that I really enjoyed was the stroke one. The way he kind of like went through a lot of it was kind of going through whether you're in kind of the hyperacute phase, acute phase, or ultimately chronic. And going through like the hyperacute phase, what he was talking a lot about was TPA and kind of like the change over time for, initially the TPA studies, you only had the 3-hour window. We've expanded it to the 4.5-hour window. But really in the last couple of years, looks like we're kind of opening that up potentially for 24-hour windows. And not so much because there's huge benefit changes. The benefit changes are kind of on the smaller side, but we're not seeing increase in intracranial hemorrhage by expanding that window. And if we're trying to preserve whatever function we can, his hot take was like thinking that, maybe in the future, this will start to expand our window for TPA. So I thought that was interesting. So talked a little bit about the Zodiac study. It was a randomized controlled trial for patients who had LVOs and needed to get a thrombectomy, and randomizing the patients into their head of bed being at 0 degrees while they await thrombectomy, or randomized to being in a 30 degrees for a head placement. With the logic being that if they're at 0 degrees, that you're probably increasing cerebral perfusion compared to the 30-degree position. However, concerns also with, increased pressures to the brain, being at risk for increased rates of hemorrhagic conversion or other complications such as like aspiration pneumonia. And for patients that got randomized to that 0-degree head placement, so laying completely flat, didn't see any increased rates of intracranial hemorrhage or aspiration pneumonias, but did see a markedly improved rate of their stroke symptoms. So I just thought it was interesting. It's not something I think about a lot, but we actually at our cath lab have to transfer out for thrombectomy. And so it just seemed like for the hospitalist, kind of low-hanging fruit is something to think about while you're trying to figure out if that LVO is getting the thrombectomy or not.
Yeah, it's definitely not, like you said, where we practice, it's not something that we actually have to think about at all. And so just, and like I think historically we've always thought about 30 degrees, everyone's at 30 degrees, and don't often see people at straight up 0 regardless of their reason for admission, to be honest.
Yeah. And so just something to think about is something I didn't really know about. And so I just like that as a little tidbit, direct from kind of the neurohospitalist mouth. I think the other thing we wanted to talk a little bit about was the updates talk.
Yeah, it's always sort of the centerpiece of the conference. And honestly, like they do such a good job in the time allotted to go through so many papers that we certainly could not go through the nuance required to get through all of those papers. So I think it's probably helpful to go through some just high points, like briefly.
They hit on some things for heart failure, some things for a lot of antibiotics, as usual, because I think that's obviously like bread and butter for the hospitalists. Some new stuff on high flow, like nasal cannulas versus non-invasive ventilation. And without like really going into too much, because I think there is some like overlap for hotcakes usually for those studies. My large takeaway was that they went through the study looking at female providers and male providers and differences. And what I took away was the female physicians are just better.
I don't know if I needed to go to a whole talk for that one to get that information, but getting the studied validation feels good.
Yeah. So that was really what I am going to leave this conference with.
Yeah, a great last point to take home. I think, overall, such a great conference as usual for the hospitalist, so relevant to what we do in our clinical practice. They try to focus in on the things that it causes pain points, and obviously our favorite conference of the year for so many reasons, one of which would be Dr. Annie Massart's cookie boxes. If you know, you know. And if you're watching on video, you really do know. And if you're not, go watch the video. But I can't think of a better way to close out covering our conference, Converge 2025.
I agree, except by our new sponsorship of Annie Massart's cookies.
All right. Well, bring us home, Meredith.
So this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more?
Yep.
Join our Patreon and get all episodes ad-free plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox, including our Curbsiders Digest recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And here at the Curbsiders, we're committed to high-value practice-changing knowledge, and to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. It also helps a ton when you subscribe, rate, and review our show on YouTube, Spotify, or Apple Podcasts. A reminder that this episode will be available for you to listen on any of your podcast apps of choice, and a special thanks to our whole Curbsiders team. Our technical production is done by the team at Podpace. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris the Chew Man Chew runs Discord. Stuart Brigham composed our theme music. And with all that, until next time, until Converge 2026 in Nash Vegas, I've been Moni Amin.
And I'm still Dr. Meredith Trubit. Thank you and good day.
Night, all of the above.